David Atashroo, welcome to Sages, welcome to Cutting Edge. I've been excited thinking about this interview all day. Your field is probably the biggest expanding field out there right now. So the talk of the town, AI, and how AI intersects with surgery and medicine. And you have a very interesting background. So you're a surgeon by training, and I guess, why don't you go ahead and explain, where did this start, how did you get involved in this, and what are you working on?
Yeah, thanks Jeremy, I'm really excited to be here and be a part of this conference, to be talking to you especially with all the stuff that Surgery Unified has been doing in the space of surgery. My background actually started when I came to Stanford. I was a postdoc there, got involved with a lot of the innovation coming out of Stanford and Silicon Valley, ended up spinning up a company, and then as I was reflecting about some of the most important opportunities inside of healthcare and the things that I felt were most frustrating for me as a surgeon, it all came down to operations. It felt like the lowest hanging fruit of things that could improve clinical care, but at the same time was the stuff that was just not my job. Not the stuff that I wanted to worry about, not the stuff that I was trained on, but had a fundamental impact on my patients. It came down to the operations surrounding the delivery of care. These are all the things around coordinating with my patients and scheduling and following up with them afterwards that have a meaningful impact on the end quality that we deliver to them that's outside of cut to close in the operating room, but I don't have the time or the capacity to be doing, and yet I want to offer the Ritz-Carlton experience to each of my patients. And so it was very natural to me to say, this is something that actually AI and machine learning can actually be very good at, to offer a personalized experience for each one of my patients.
And I think that this is something that a lot of surgeons may not fully understand. Can you walk through, when you say machine learning or you say AI, what exactly are we referring to with these terms?
Yeah, so when you think about machine learning, think about it as an algorithm that can learn without being explicitly trained. And AI is the broader field that encompasses machine learning, where there's supervised machine learning, unsupervised, and then deep learning. And then inside of that space as well, you have language models, which we would consider a component of generative AI. And this is another area of the field that is really exciting, because it fundamentally changed the game on the types of things that we can do and the problems that we can solve. Previously in this space, there was a lot of, I would say in healthcare, you have to reach a requisite bar to deploy technology into production, because we're talking about patients and their lives, and we can't afford for technology to be somewhat performant. It needs to be as good and hopefully a little bit better than what a human can do. And one of the things that came to bear with the advent of the foundation models, and you've seen this in OpenAI and Gemini and ChatGPT and Llama 3, these models were developed in such a way that they could start to do things almost better than a human, with close and approaching to generalized intelligence. They could read charts, they could text with humans, they could talk to humans, they could do it in 10 different languages, they could do it at any time at night, they could ingest the entire clinical context for a patient and use that in order to have a conversation with them against a clinical workflow that we prompted it to do. And I think that is what became really exciting in the state of the field for us.
Yeah, I think that what we're seeing obviously is just a small piece of the bigger pie when it comes to what AI is capable of. Because we hear, right now we're talking about Surgeon on Scribe ourselves. We have AI that can do scribe features. We talk about it in terms of its ability to analyze the data, potentially locate issues in surgical patients that we didn't realize were causing a complex problem. But beyond that, where do you see it that surgeons probably don't realize? Like, where's it going that in the field that we would just be mind blown by?
Yeah. I think if we talk about the mind-blowing piece, I think one of the things that I've been most excited about is like the advent of actually precision medicine. We've talked about big data since the 2010s, and yet we've not been in a position, the technology has not been advanced enough to actually assimilate all that big data and take it from some sort of an insight into an actual action. But we're finally at a point to do that. So if you think about the different types of data that can now be assimilated, there's a bucket around video data coming off the robotics, so that can be used. There's a bucket around omic data. So think about genomics and proteomics and all the things that make the unique biostructure of a person. That can be then pulled. There's all the operational data from a patient's flow inside of a hospital. There's all the dynamic data, all the things that are coming off of instruments and monitors for patients. Previously, we've never been able to use that to offer personalized care. But now with the advent of generative models, all of that information can be used to actually offer precision medicine to a patient. Meaning the same patient with a colorectal diagnosis that's 45 and female, based off of their unique preferences and patterns and genomic data and then dynamic data, we can actually change the way in which we deal with that patient to offer them better care. I think that is fundamentally different than anything that was possible in healthcare. That would be really exciting.
So what you're looking at is truly personalized care.
Truly personalized care.
Because there might be variables that we don't realize in their history, in their genetic make, whatever it is,
Totally.
that we can't account for right now because one, we have no way to run the, let's say, the calculations or the best fit models, whatever the models are.
That's right.
And so you need this to really be able to look at that data in a much more detailed way.
You think about like, how do we think about practicing medicine today? It's evidence-based guidelines, right? We think about clinical practice guidelines. But when you look at those are at best almost always heuristics, right? Patient is this age, they have these comorbidities, they had this score against a specific heuristic model that we built, and therefore we take them down this treatment algorithm. It stops there. It has nothing to do with their socioeconomic factors, the way they've responded to previous interventions, the different medications they've taken in the past, what their proteomic or omic data is, what might have happened during a previous surgery or what we saw when they previously had an operation or learned about them. None of that gets taken into account when we actually determine what treatment path to take them down. And so this is a fundamental shift that's possible in how we treat patients that goes well beyond how we've normally thought about consensus guidelines for treatment of patients for conditions.
In some respects, and my understanding on this is, people worry about us developing these AI models. Of course, there's the worry about AI when they hear it, and probably general AI is what they're worried about, but it almost had to happen, correct? Because we have so much data being produced all the time that humans themselves are incapable of managing these large data sets, and so you had to find some way. So over time, it was an engineering problem that was going to have to get solved, and that's how we end up here, correct?
That's right. There was a lot of pressure from it technically to be designed, but then there's also just the pressure from the consumer end of, I think people were expecting this. How many people have been to the doctor, engaged with healthcare, and their perception is like, I don't understand why you have all this data on me, and yet it doesn't somehow seem to factor in at all with the type of care I'm receiving. So there's a lot of pressure from the consumer world to say, make this data useful. And I think it's the same from the provider world. We have been asked to put so much into the EHR, and yet we think to ourselves, like, why isn't this being used in any way to help advance the care for the patients that didn't depend upon us to go back and assimilate it and use it and put it to use?
And even at the lower level, just the fact that its ability to place the data into structured format without you having to literally go in there and apply it. I mean, that interface up until now has been crap at best because it's so much time to structure the data properly, where now the AI simply does it for you.
Yeah, it is a fundamentally different approach to say to use a language model to say that it's not prefaced upon you structuring the data, it's not even prefaced on having high data quality. It can take into account low data quality, it can use entirely unstructured data, it can pull from a multimodality of sources, and not only can it compute it, it can then, I think that one of the biggest advances is its ability to put it into action, to meet patients where they are. If in the old paradigm of saying, well, I'll deliver you an email report, I'll give you an insight, and now someone has to go do something with that. Well, who is that person? Are we going to ask more from the coordinators that we have that are already overtaxed? Are we going to be asked to hire a bunch more people to then make phone calls or coordinate with patients? That's not tenable in the current state. We have to figure out a way to extend the current teams. And I think what's different is now that you have a digital assistant or an operational assistant that can come alongside the care teams, take off the 70% of their work that's below the top of their license, and fully automate it and offer a better experience to the patients while doing it.
No, I think it's quite impressive. And one of the conversations we had a few months ago, it really was eye-opening to me, is it's not like a lot of these systems aren't one AI model. Like you're using this language model for this, and then you're kicking that output to another model that's running this. Could you kind of walk through what that looks like? Because I think people have this misconception, like it's this giant one-time AI thing, but it's really not. It's a bunch of systems that do different things.
I think that is a really good insight. We are not at the place where you can have a generalized model that is really good at doing all the specific things you need to do inside of a clinical workflow in healthcare. What it takes is actually building an ensemble of models, is how I'd like to think about it, that are really good at specific tasks, and then you're putting an agent, almost consider like a supervising agent, over top that has a specific objective that it's trying to achieve, better patient care or adherence to a clinical workflow, and then it has all these other agents that can then go and be at its disposal. For instance, you have one model that's doing risk determination and risk stratification for a patient. You have another agent that's maybe a patient concierge, just texting with the patient and coordinating with them. You have another agent that's doing chart summarization. It's doing all of the distilling of all of the data to be used by the other agents to make the decisions. You could have another agent that's doing the actual outbound coordination. It's going and collecting outside records and going and collecting information from other places to assimilate it. So these things have to work together, but there's not one thing that does that really well. And I think the other thing to think about is that you're not throwing out all the old technology. The right way to think about developing solutions in this space is what's the right tool for the job. And there are times when a generative agent is the only way to get the job done. But there are other things like taking the space of risk stratification, where that is truly a supervised machine learning problem. We know the input set and we know what outcome variable we're trying to optimize for. And you're training a supervised machine learning model. What's different now is that you can now rely on an agent to pull in way more features than you could before. You can improve the learning data set tremendously because it can leverage all this unstructured data in building out that model. And that is where like these things actually kind of work hand in hand.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. Surge On, where surgeons go to explore, discover, and learn.
Where do you see pushback when you're out talking to people at the surgeon or the professional level, and where do you see pushback from the general population? Is there any questions that come up regularly, or is there a lot of...
At the surgeon and the professional level, I think it's just how can I get this yesterday? I have been so frustrated with these types of things, and what you kind of need to overcome is, in our field, there's a little bit of, we have been disenchanted with our attempts to do this. For 20 years, we've been trying to partner with IT and administration and trying to push the ball forward. And it feels like we've given a lot of time and it's just like banging our head up against the wall. No progress is ever made. We sit in hundreds of committee meetings and no decisions ever made. And so in some ways, surgeons want to believe and they want it yesterday, but you have to overcome the hump that it's now finally possible for it to be achieved. On the administrative level, I think the hardest thing the administrators are up against is a fewfold. The first thing is it's got to be safety. Safety is the number one thing. First and foremost, we have to make sure that what we are deploying into patients is actually not going to hurt them. We have a creed to do no harm, and so it's right that that's front and center. That we need to be comfortable that the things that we're doing meet the level of safety that is a baseline for clinical practice. The second thing I think has to do with financial. Every single institution is in this place where they want to adopt AI, and yet they're not in a position to waste a bunch of money doing it. And so having an understanding of how is this AI going to be used and scaled, how do we know that there's a financial ROI to be had with this, is really important for institutions. And then I think the third thing is there's a lot of tech consolidation or vendor standardization that's happening within the hospital systems that we work with, where they don't want to have a disparate amount of systems to manage inside of their platform. And so they're really truly looking for platform partners that they can solve a multiplicity of needs with. If they're going to go outside their EHR, and there's a lot of reluctance sometimes to even do that, who are the one or two vendors that they can work with that they can do a lot of things with? So I think that is some of the resistance that kind of prevents people from taking action. I think the bright spot of this is that we've found that there are really good answers to all those things, that there are leading institutions that want to engage in that type of a conversation and can very quickly, inside of a quarter, be in a place where they're seeing a financial return on investment, even enough to pay for the solution, and putting themselves in a position where they've gotten started, built confidence, and now they're looking to scale.
Now, is there any oversight body that's being developed? Is there any group that seems to be trying to get involved?
Yeah. It's a really good question. I think on the hospital side, what we find almost universally is every hospital system is standing up a new entity to manage this that they haven't done before. They often call these AI governance bodies. And these AI governance bodies are becoming the checks and balances layer, where all of the potential innovations in AI are coming through these layers to check those boxes. They're almost, and there's organizations that are actually doing this, almost creating, think of it like a recipe card on the back of a nutrition label on the back of a piece of food, where they're saying like, okay, what type of model is this? Is it safe? What type of data elements does it pull from? Does it touch HIPAA or not? and that way having some type of a heuristic to score different models to better understand them. So there is that standardization that's happening. There's also those AI governance bodies that are getting stood up. And then on the industry level, I mentioned there's organizations like Chime that are coming together to say, how do we help the health systems that are evaluating these technologies have a better understanding of what they do and what their capabilities are.
Which makes sense, because it seems like you're jumping into a deep ocean if you don't really know anything about this. I mean, we went from the understanding of AI probably 18 months ago, like people are hearing about it, to now it's basically a supercomputer in your phone that you can get access to one of these models.
It is a really good observation, and I think the hard thing is it is almost unfair to ask anyone, even inside of a health system, to stay fully abreast of this, because the state of the art is changing so quickly. In the work that we do, we are constantly reinventing our platform month over month over month. There are certain components that stay the same, but we're constantly testing and trying new features, as in the space of generative AI, there is a order of magnitude increase in performance or cost on different models that are being released. It seems like effectively every quarter, and new ways of doing things. And so staying abreast of all of that is very difficult. But the big thing I would push back on is, I think the shame for our patients would be if there's an analysis paralysis of saying, until we can get fully comfortable, we're not going to try, or until we can fully understand everything, we're not going to get started. The only way to actually start to get smart and understand how to do this is to start to engage with it. And that means actually starting to try the technology in a meaningful way and see what the feedback is from your providers and your patients as they start to use it.
This is a little kind of a side question, but how do you maintain, or especially we're dealing with patients' lives, we're dealing with very complex stuff in medicine, how do you know that the outputs you're getting are accurate? Because we have seen through some of these models, especially in the earlier generations, that it can come up with false publications come out of it, or just the outputs. Are you able to see into the actual algorithm and really understand where it's getting that from?
So that's a tricky. So I think what you're talking about is hallucinations that happen with AI models, and whereas it's very difficult to understand the reasoning behind why the model made a decision, which is one of the challenges of generative AI, it is very possible to score the outputs and prevent those hallucinations. There are things that you can do and that we do to prevent those hallucinations. One thing is through strong prompt engineering to make sure it understands the task at hand and its guardrails. One thing is by limiting the data set that it has access to prevent its ability to hallucinate. The third thing is you really need to set checks and balances in place. So when we deploy models, we use a combination of both models testing models and also humans in the loop to be able to score these models, to make sure that we're using clinicians to gut check. Is the model performant? And especially when we launch with partners, I think it's really important that the partner gets to a comfort level to see that the model isn't just more performant in some areas. It's avoiding any of those never events where we feel like we have really negatively influenced patient care because it's missed something or misadvised the patient. And so there's a whole infrastructure that needs to be set up in order to make sure that we are accurately monitoring these models when they're deployed, because it's a very real concern to make sure that they're not hallucinating, and that risk is really dependent also upon the use case and the workflow in which they're being deployed.
Well, absolutely. And I have to think that there's a certain irony here that the expectation of the model is going to be perfection. Whereas if we maintain humans in the system, there's obviously not going to be perfection.
I'm really glad you actually brought that up. That's actually really, I think, really wise of you to mention, because we both know that our own teams aren't perfect. And if the bar is perfection, that will prevent any progress. If the bar is, can we be better than where we're at today? I think that's a lot more of a fair position to be in when it comes to how do we think about deploying these models. And especially if we think about it as these things as assistant to our own teams, I think that also helps us get comfort that they're not oftentimes models just operating independently and indiscriminately on their own. They're still being controlled and moderated and often used as an assistant to the humans, not a replacement of the humans.
Yeah. Who do you think is going to be most affected by this moving forward?
It's a great question. I thought a lot about this, and I think you have to have a certain empathy for people whose jobs are predicated upon some of this work that was pretty manually done today. I do think a lot of the below top of license manual work tasks that took a little bit of clinical knowledge but was mostly repetitive in nature would be the people that are most affected. That being said, I've been really inspired by the way that health system execs are approaching this. And when they go to their teams, the way they're approaching them in this conversation is to say, we want to upskill you to do something else. We want to work with you to develop you, to help you do a job that an agent can't do, because an agent can come alongside you and do this part of your job. Where the people that will be most negatively affected about it is if people have lacked the interest to be upskilled or to change, I think it'll be difficult for them.
Well, I gotta say, I was a little, Sage's MBT, you were there a couple months ago, and the discussion over automation of surgery even. I mean, we're looking at, they were saying that only a few weeks prior they had the first robot learn how to suture on its own, and you start to look at it and go, how far removed are we from the ability to start doing some of these basic procedures robotically without a human interaction?
I think it's a really interesting field of exploration. I think you're safe for the next 20 years. There is still so many variables that a human mind can compute, and the downside risk is so high. I still think we're a ways away from being able to turn over control for the critical parts of the surgery, let's say that, to a human. And at the same time, I do think there is something interesting here. I mean, we think about surgery today. We know that there are parts of the case that are highly repeatable. These are the parts that we can feel really comfortable with our advanced practice providers and our medical students and our residents doing portions of these cases. Then there are highly critical portions of the case that the attending really needs to be in the room when those decisions are being made. I think if we see it as a zero-sum game, all or none, I don't think that's the right way to think about it, but I do think there's an opportunity to say, what are the portions of the case that are low risk and highly repeatable, that if a machine could take those on, it would allow the surgeon to do more of the critical parts well and better serve patients.
I have to tell you, I was sitting across from Dr. Phil Corey at MBT, and we were having the same conversation, and he said 5 years, and my jaw dropped. I was like, but I'm seeing the rate of growth, and I couldn't put it outside. I would say it's probably earlier than I would expect, knowing as an engineer background, it's always longer than you think when these things are developing, but it is happening so fast. And because of the exponential growth that it could occur as you guys move forward, I mean, who knows? Maybe it is a little sooner than we think.
Yeah.
I'm hoping. I like your 10 to 20 years a little better, though.
I do think, though, regardless of what the situation is, I think, one thing is clear. It behooves us as the clinicians to engage with this type of technology so that it's developed in the right way. I'm not saying that we're trying to speed the future, but I would say it's a much more dystopian future that will be developed if we're not at the helm working with the technology companies to think about the right way to do this. There is a lot more negative patient impact and professional impact to us that will happen if we don't make a firm decision to say, we're not going to put our heads in the sand. We are going to go out and be at the forefront of partnering with industry and the technologists in the development of these technologies.
And that's one of the reasons I was so happy to have you on here, because you really are one of those people that's sitting at that intersection between clinical expertise and knowledge and the technology and really understanding it at that cutting edge. And I think that having people like you at the forefront of this is a huge advantage for us. So I'm very appreciative of what you're doing.
Yeah, a real pleasure to come and speak with you today, Jake.
David, thank you so much for your time. And once again, welcome to Cutting Edge.
Yeah, awesome.